I feel like that graphic, it's like John's on an island. Like, here's Liz and Chris, and then there's Dr. Grayson over there.
Floating
Um,
away.
oh, that's so funny. Okay, good to see y'all. Welcome, welcome. Hi, everyone. Please put in the right-hand column, please let us know who you are, where you're joining from, questions you have. We are so excited about today, and I'm like jumping in right away, Chris, because John, every time we have you on, we run out of time and we tell you we need you just to be a permanent guest. So I know that will happen. So here we are to jump in. Couple quick housekeeping reminders. The conference is coming up. Please go to iocdf.org. Consider registering. It'll be amazing. All of us will be there. We're so excited to just see everyone connect and be together once again. And of course, share updated knowledge, information, and presentations on OCD. This live stream is not intended to be treatment. It's intended to be educational and to provide resources and support. Please make sure you have your own treatment provider for your individual treatment. And of course, if you're feeling unsafe or suicidal, please call 988, which you can now call nationally, which is amazing, or of course, go to your local emergency room. So excited to see y'all. I got a huge bio from you, John, but like, I'm not going to read it because I don't want to. And we don't really need to. Like, I think the best way to introduce you is to let you kind of talk and share kind of your own background. But really what everyone needs to know is that Dr. Grayson is a leader, a founding expert in ERP, and I would say founded and coined uncertainty for OCD, and is really the reason we know a lot about how it works, the mechanisms behind it, and why we use it in OCD treatment. I will also say personally, he's an incredible friend, mentor, and colleague, but also someone who I think that you're one of the few clinicians I know, John, who doesn't have OCD, but you're able to relate to people with OCD as if you do. I always talk about that conference I attended where I was probably like 19 at the time and was like functioning with OCD, right? That's what I call that stage of like, I held it together. I looked fine from the outside, but I was really struggling. And I remember you came up to me and you were like, so Liz, what's really going on? And I was like, I'm fine. Like, I'm fine. I'm here. I'm doing fine. And you were like, but you're not. And I can see that you're not. And like, let's talk about it. And it was so meaningful to me, and it stuck with me for a long time because it really, you share a lot of examples about empathy we have to have for our patients and what that's like. And I think you just exude that, and you always have that, and patients feel it. So thank you for who you are. Thank you for what you do. We're so excited to have you. And we know today is going to be awesome.
Can I copy that and use that for my introduction from now on?
Yeah, please do.
Actually, you can just hire Liz and she'll follow you around. And anytime you walk into the room, it could be a grocery store, it could be the DMV. She's just going to announce.
Here I am.
And say that whole speech. And they're like, oh, great.
Sounds good.
You know what, John, to kind of kick us off, I have a question because, looking at your bio this morning, and obviously I know your background, you've worked with a lot of clients with OCD. If you had to kind of pinpoint maybe the top 2 or 3 things that you see when a client shows up to your office, what are some of the things that you look for and you feel like, okay, these are the things that people bring to the table, and I know they're going to be able to get better? Obviously, if they're working with you, they're going to get world-class treatment. You're going to do your part, but what are some of the things that clients should show up to sessions with, either a way of being or something that they do that makes it more likely that they may be successful in treatment?
I'm pretty optimistic that, people can always get better. I think, I think there's some willingness to decide they want to learn to live with uncertainty. And when I say willingness, I don't mean that they agree that session. I remember somebody that I did an OCD stories with, so I can talk about him. He had been afraid that he would go crazy. And at our first session, I said to him, well, our goal is to have you risk going crazy, which made him cry. It took 3 months for him to truly agree. But he wasn't like fighting all 3 months, like, no. It was just really hard and scary. And we kind of went over it, as opposed to like, this is not acceptable. Nope, not doing it. So he was really trying. So I think that willingness to try to cross the bridge, no matter how hard it is always pretty hopeful. I don't know that I have a whole bunch of other like visible traits. So I can't answer your question better than that.
No, you answered it well. I think an openness and a willingness. Just like you said, I think sometimes people think they have to come into treatment and be 100% like, I'm ready to do it all. And I think obviously that's always the dream client, but coming in at least being open and willing to listen, it sounds like that is a huge factor in things that you see in clients that get better, which is good. Do we want to jump in? We already got our first question. So at 12:02 your time, Amanda, it's from Michael. And he says, I suffer from compulsive staring and it really makes me feel uncomfortable. How do I deal with this?
I think compulsive staring, I think, is the one form of OCD that we have the greatest difficulty with. So there are some things that, like I feel for all other forms of OCD, although treatment can be exceedingly hard and really difficult, I feel like if the person will persevere with it, they can get through it. Compulsive staring, I think, is really scary, because I think we have a kind of treatment, but I think it's very difficult. And I think there are two things we tend to do with it. One, in all OCD, part of what I always say is, coping with the uncertainty is like, how would you cope with the worst if it happened? So with compulsive staring, and we have two groups of people with compulsive staring. One group actually doesn't stare, but they think they do. But the other group actually stares. They've really been caught. They tend to overestimate how much they're caught, because sometimes they like try to avoid making eye contact, so people are looking at them funny. They think it's because they're staring, but actually it's because they're looking funny. But they are caught staring at time. And so our backup of what to tell people, we never tell them to say that they have compulsive staring, because nobody in the world knows what that means. So, if I am looking at your genitals and I have compulsive staring, you are not comforted at all. So we've kind of labeled it visual Tourettic OCD, and this may not really be accurate in terms of what it diagnostically is, but to say to somebody, oh, you've heard of Tourette's, you have that cursing thing, this is like another form of it. And I think as an excuse, people would kind of get that. So I think it's always good to have my backup excuse. One of the things we do with it is, ultimately because one of the things that happens is people will do the staring. They're trying so hard not to stare that often leads to it. So one thing we do is what we've labeled sneak peek, which is actually, I want people to stare, but I want them to do it when they can get away with it, which is kind of almost what normal people do. You come up and you're actually seeing somebody. It's like, you're trying to look when you're out getting caught. And that will help avoid a whole bunch of occasions and get rid of some of the anxiety. It still is very hard because it's something one has to be conscious of all the time. I think it's an area that we need a lot of work. So there's some things to do, but I don't think it's like we have the silver bullet yet. And of course, it's an area that I think very few people, if anybody, are researching it. So it's an area in great need.
Well, it's kind of a follow-up comment from Matthew at 12:04. He says that research and the stuff that you put out so far on visual Tourettic OCD has been really helpful and game-changing. I know you did do a live stream about it that we usually showcase here when people ask about it. Anything else like coming up, or anything they can read about it that you're putting out, or anything they should know coming up?
Not for me, and I haven't looked at it, but there is, I believe, a woman who's written a book on it, which I haven't looked at, so I don't know how good it is. But hey, nobody else is doing it, and I'm sorry that I don't have that reference, but I'll bet somebody here in the audience may have it and will flash it up for us.
Well, there was another comment from News Park who's dealing with it as well. So I feel like they said they're struggling with staring OCD. It's been frustrating. Can't find help. So I think if you write a book, it seems like there's a lot of people that really do want your help from it. So I think it would be good, or maybe a part 2 to the town hall you did previously.
Mm-hmm. Yeah, I think maybe at the not for this one, but for the online conference in October, I think I'll submit it and do a talk on the compulsive staring there.
Yeah, I mean,
Yeah.
Oh, go on, Liz. Sorry.
No, I was just going to say, I think that one of the things we find is that there's, I guess what I want to ask you is, why do you think this is a more difficult, like, why do we find that some subtypes of OCD feel a little bit more difficult to treat? Is it because the individuals are like not willing to not stare, so it's a little bit harder for us to or not willing, but like they have less control over that, so it feels harder to prevent the compulsion?
Well, I think it's harder because it's not. I mean, you know, I have this thought that sometimes, a lot of OCD is uncertainty based. Um, I really can't say that this is, there's some parts of this that are OCD. That is, there are times people think that they're being caught when they're not, so they are oversensitive to that. But the actual staring is not a ritual behavior. That is, they are, it's not like hand washing where I just can't stand and I give in. It really is unconsciously done. There are a few times we thought we figured out like what the key was, but it turns out that was just covered subpopulations. So I think, in that sense, and I said it's, is it actually Tourettic? And I don't think we can say that because we would need a lot of research. But there's that similarity in that it's not a voluntary behavior. It's not, but again, when you talk about Tourette's, people think of it as involuntary, and it's actually described as non-voluntary. That is, somebody with Tourette's can actually suppress it, but it's really hard. And this is, happens again often without people realizing, which is what makes it hard. Because to be conscious all the time of like, I need to do my special staring technique so I don't slip, is really hard. So I think it has to do with that non-voluntary aspect of it.
Absolutely. Switching gears a little bit, we have a question at 12:06 from Ranji on YouTube. They ask, sometimes planned exposures, ERP exposures, can become a ritual, like invoking your fears again and again to check how it is working. How does somebody work with that? So when their treatment starts to become compulsive, where they're doing it almost to check, what would you suggest they do to address that in treatment?
They need a coin. Or I prefer, there's an app I love called Roundom, ROUNDOM. And what I would do is I would basically flip the coin to decide whether I do exposure or not. Never ritualizing, but the coin would determine whether I do exposure, so that kind of interferes, so it doesn't mean I stop doing exposure, but it also means like I don't always get to do it. But I was using Roundom. Roundom is kind of cool, the paid version, because I can set how many pieces of the pie there are. I can have it for 2 choices or 4 choices. So I would make 2 choices exposure and 1 choice no exposure. So I tend to do exposure, but that way it's to the extent it's a ritual, I don't get to do that. So the Roundom becomes God and decides whether I get to do an exposure or not. So I get to do both. I don't lose my practice, but I don't get to do the ritual, if that's what it is.
I love that, because obviously what happens is OCD becomes so much ritualistic. It can turn anything, I think, into a compulsion. And I think always when it attacks the treatment, it's the hardest, because people are like, well, I'm supposed to do my treatment to get better, but my treatment has become compulsive. But what I like about what you just said is that with the random component, it's really hard for OCD to latch on and create a pattern, which it wants to so bad.
Yeah, it's like, we can do treatment wrong and still do it right.
Exactly. And I think that's what's hard for what I've noticed. I don't know if you noticed this, but when clients really get OCD about their treatment, they typically like to be perfectionistic and do things right. So it's almost like a double exposure for them to do the treatment wrong, because they're so used to hearing it be,
Exactly.
Done right. And then their personality is to do things and complete it correctly. So then doing it wrong becomes this whole like thing in their head. There's a comment from Kayli on YouTube. I didn't know about this, that you and John Hirschfield had a contamination eating.
I was reading about this. I'm scared to know, but I kind of do want to know.
Oh, this was
at the conference.
This was early in John's career, when he wasn't known, and there was a dinner where a bunch of experts were eating dinner, and John has wormed his way into the dinner. And he described, he's sitting across from me, and he described that he was thinking, I've got to do something. I've got to make a move. I've got to somehow make myself known. And we're eating pizza, so he takes a piece of pizza and contaminates it with something and hands it to me. I take a bite and I contaminate it and give it to him, and we go back and forth until I ask a woman next to me if I could borrow her shoe, and she of course knew what I was going to do, and I put her shoe on the pizza, took a bite, gave it to John, and he took a bite, and I didn't say it, but I thought in the back of mine, you're great, you're a nut like us. So that was his getting his way into the field.
Well, what
I guess it worked.
Yeah, what I wanted to ask is, because I've seen it, not with the pizza, but when you did a talk that I attended in LA with Barbara Van Oppen, you put like the muffins that they give you at the hotel on the ground and was like eating pieces. Do you find that, because sometimes people are nervous to do exposures and they're in the session, they're like, well, I'd never do that. Do you find that when clients go above and beyond like that, like eating a muffin on the ground or pizza on the shoe and stuff like that, that it tends to help them get better quicker? Or what do you find is sort of helpful with that?
Two things. One is, I think we always need to take exposure to that level because, but more important, everything I do actually really occurs. So although we typically don't put muffins on the ground, but on the other hand, how many people in college were at parties where they were sitting on the floor, hands touching the ground, and then they ate something? How many people, if no one's looking and something drops on the ground, if they don't have OCD, it's like, all right, the supposed 3-second rule, So, and although I always wash before I eat, but again, at a party, one doesn't do that. In terms of, if we go to a restroom and I don't wash my hands, which I never do, and if I touch a wall, you then don't want to really touch where I touched. And if you were to touch that, you'd be concerned. But do you know what everyone who does not have OCD does after they go to the bathroom, but before they wash their hands?
I don't know.
Touch their pants.
Oh yeah, touch their pants.
Right. So that means their pants or dress is contaminated, and they're touching. It's like if I touch the wall, they touch that, and then they're contaminating everything. So actually, the entire world is contaminated. So we're always, we there are things we say we would never do, or my favorite, as long as you brought it up, I love at conferences where I'll convince people to chew ABC gum, already been chewed.
I hate that thing of yours.
And I point out why it's normal. Now, everybody would agree that if I spit on a plate and ask you to lick it, you would probably tell me where to go. But how many people in college French kissed with somebody they didn't really know that well? And you're going to tell me what is more, which germs are fresher, French kissing somebody you don't know or 8-hour-old gum, which, by the way, 8-hour-old gum is as gooey as if you just pull that out of your mouth. So I'm doing something that seems like, oh my God, but actually gets done regularly. I do think French kissing is better than ABC gum, but in terms of exposure value, they're the same. So pretty much everything we do is actually being done. It's just, yes, we are doing it blatantly. And that's why it becomes important to do something like eat off the floor, because, if I have OC contamination, I will find a concern with, oh my God, somehow this has touched the floor. I mean, people without OCD, will take their shoes off and they're not really concerned where their hands touched in the shoe. That same person won't rub the bottom of their shoe and put their hand in the mouth, but they very well may take their shoe off, touch the bottom, put it down, and not think about it. Because, think about people without OCD, and I think many sufferers have noticed this, they don't know what they're doing. They have a whole set of standards they think they have, but they actually don't know what they're doing. All right. And our goal is to help people be unconscious like that ultimately.
Yeah, I mean, it's funny because it's like, to me, it's like I've never thought of it that way, but you're correct. It's like you go to parties, not Liz, of course, but in college, because she was way too good. But the rest of us, we went to college parties, and you're right. You like make out with somebody, and then it's like you don't even think about it. You've never met this person. You don't know what they did before you guys kissed, and we're willing to do it. But then in the context of exposure, people are like, well, I'd never do this. But then I've never put those two and two together, but you're right.
Well, that's the thing, right? Is Sorry, John. So, I mean, I think the thing is that when people like the biggest negative we hear about uncertainty is when people will say things like, well, if you didn't have OCD, you wouldn't be doing this. So it's like torture and it's this thing that you're asking people to do that's ridiculous. And all of us that are clinicians are like, not really. Like, we shouldn't be asking someone to do something that's actually dangerous, right? I don't go ask a patient with an HIV fear to go put their hand inside of a needle box, you know, like we don't ask you to do things that are we wouldn't do or that we've never done, right? We're asking you to do things that, yes, sometimes it seems bizarre to sit on the floor and eat, but I can promise you, if you're like me and you have two toddlers or a toddler and a baby, like they sit on the floor and eat every day and like it happens. And if, you know, so I'm like, oh yeah, that's totally normal. Like, oh, that's super sanitary compared to what else I observe in my household right now. I have a daughter that's potty training. It's quite interesting. So, you know, it's like, I think that that's what's really important for us to remember is that, you know, one of the statements I loved a long time ago is that there's a big difference in someone without OCD saying like, well, that's gross, or why would you do that? Compared to someone with OCD feeling like it's dangerous and it's scary and it's risky. And there's a big difference in that, right? Most of my family might be like, oh, that's gross, but I guess I'd do it if you wanted me to, compared to someone with OCD saying like, there's no way I can't do that. That's dangerous. Something terrible could happen.
Yeah. And in fact, you know, I used to joke, but now I think there's evidence it may be true. You know, I used to always think that at some point we're going to find out it's actually healthy to go into dumpsters. And, you know, I was looking forward to the time when I have somebody with OCD where it's like, no, you can only go in the dumpster once today. But there may be some evidence that actually it does improve the microbiome. And, you know, maybe it's why you know, having done this since 1978, that I'm not, you know, sick and dead from all the exposures I've done.
Well, you know what? I will tell you, I actually am starting to really believe that, and I'm clearly not a medical doctor, but my kids are like it is awful. I feel like I'm in the plague right now because they're just nonstop sick. But the doctors are telling me, like, I literally was like, does my daughter have an autoimmune disorder? Like, what is happening? And my doctor was like, Liz, like, I know this is awful, and I wish that like I could explain it to you in different terms, but like COVID has made it so much worse because we had no sicknesses. People were exposed to nothing. And now they're just getting exposed 24/7. Like my kids will literally get a new virus, be fine for 3 days. And then it's just it's nonstop because there's like, it's almost like, yeah, there was no exposure at all. And now it's overexposure. And doctors are talking about that all over the country, right? I can't speak to the biology behind it, but to the fact that because COVID created this like world of isolation, right? And it needed to, and we didn't understand the virus and that made sense. It's like, you know, maybe dumpster diving is healthy to a degree, right? We're building up some immunity and maybe we're slow dosing it versus overdosing it.
You're reminding me of my daughter-in-law's face because, you know, the first month or two, you know, the doctors are very careful about the baby. And then I remember when she went to this point where like the doctor's like, okay, you know, no more sterilizing. You know, we want your kid to get sick. And she's like,
what? Yeah.
What?
No.
Like, oh yeah, we want him to get real sick right now because that'll be great later. And you know, her face was like, you know, a little bit in shock as she was trying to like take in like, wait, we want him to get sick.
Yeah.
And he complied.
Yeah. He complied. See, that's that. My daughter's complying. She's following instructions. So I'm grateful. No, I have so many questions today and sorry, Chris told me about an extra noise. So hopefully it got fixed with my AirPods, both being in now. But one of the things that I'm seeing a lot of, John, is just continuous, right? And this is like a pattern. And we all know this with our world is that there's this like ERP group, and then there's a lot of other groups that things pop up, but also we tend to see a lot of like overdiagnosis of certain disorders, underdiagnosis of other disorders, right? We know that for a while, there was like an overdiagnosis of bipolar. And so anyway, one of the things I'm seeing, and I'm struggling a little bit with this clinically. So like, I want to hear from you with the expertise you've had is this kind of like over prescription, if we want to call it, of DBT. So finding that like, a lot of patients with OCD may actually need DBT as well, right? And we can agree that there's times where it's like, okay, like a DBT referral makes sense. So DBT, for those who are listening, is dialectical behavioral therapy. It's often it's an evidence-based treatment for personality disorders, but is also really used to help people who struggle a lot with emotion dysregulation or interpersonal difficulties. And so one of the things I'm really wanting to know more about, because I'm just trying to understand it clinically, is when I was a teenager and I first went to treatment, I feel like I would have gotten referred to DBT nowadays, because when my OCD was triggered, I was super emotionally dysregulated. And oftentimes it appeared that like, okay, like this is a bigger presenting issue maybe than some of her OCD symptoms. And so anyway, the thing I'm trying to ask is like, how do you clinically figure out, okay, this is OCD and we're going to continue to use ERP, versus when we start to think about modalities like DBT and things that are very proven for emotion regulation, but not a proven intervention for OCD, and how do you navigate both?
I don't think that the two are in competition, right? Because I don't think it's ever
Right.
DBT versus ERP. And I don't think there's anything about the two that contradict one another. So because I think the thing is emotional regulation sounds really wonderful. Like the idea is, it has that sound of like, I won't be upset. But, of course, really emotion regulation is partially learning how to not be controlled by emotions and how to cope with emotions, right? So it's, this may not be a great analogy, but imagine two people, and imagine two people with a headache, and one person's afraid it's brain cancer. So their response to that headache is a lot wilder than the person who would like it's a headache. They both still have a headache. So, if I help that person realize, help them treat it as a headache, well, it still hurts. And I think the same is true with emotions in that sense. How do I learn to cope with emotions as opposed to being completely driven by them? And that takes practice. So I think there is a group of people. I think with OCD, of course, there's incredible anxiety, but I think for some people, the feared consequences are directly related to what their OCD symptoms are. If I have contamination, am I afraid of getting sick? But there's another group where not only is the feared consequence of that, but they're equally afraid of their anxiety. So really, that is, just getting anxious is really terrifying. And so I think, besides doing compulsive exposure, DBT actually fosters and helps us do exposure to those kind of things, because it's helping us with mindfulness. So I think, do I need a full course of DBT, or is it something that I'm incorporating into the treatment? And I think both ACT and DBT are things that we add into our treatment, when necessary to improve treatment. And I think the biggest issue is not so much do I use them or not, but are they integrated and incorporated into treatment, as opposed to as if I'm doing two completely different treatments. I think they really need to be done in a way where it's blended. So in that sense, somebody could identify, oh, you're doing a DBT thing there, or you're doing some ACT thing there. But on the other hand, it's so integrated, it's not like, here's our ACT part, here's our DBT part, here's our ERP part. I hope that answered the question.
No, yeah, I think that's really useful. And I think that it's just a really important thing for us to talk about. And Chris, maybe we could do an upcoming live stream on, again, I know we've done it in the past, but like on anger, frustration, and emotions and OCD, and how we kind of deal with both. It's just always something that's always in the back of my head. I remember when I was 17 in treatment, before I was in my treatment program, I punched a hole in the wall. And I remember going back to treatment, and then they made me go to anger management. And I was so pissed, because I was like, I don't need to be at anger management. Like, I don't actually have anger problems. I was frustrated with my rituals. And like, this was about my OCD. And if the OCD goes away, I'm not angry. Like, I'm not, right. But I also understand, there's natural consequences if you punch a hole in the wall like that. That is part of, like, maybe I wouldn't do it again, but it is interesting to kind of say, okay, and like, where's it rooted in, right? We hear this a lot with depression, where at times there is a comorbid depression diagnosis, or maybe even a primary depression diagnosis that needs to be addressed simultaneously or first. But if the depression is due to the OCD, at times we see the depression really decrease when OCD decreases.
Right. In the case of depression, of course, the meds that are useful with OCD happen to be antidepressants, so it does double duty.
Yeah.
I wanted to add something to the conversation that Liz brought up. Sometimes we get in our comments people thinking like, okay, ERP hasn't been working, or we've heard of this treatment. Does this help? We had some stuff about, question about IFS last week and things like that. In all your years, I mean, I like what you said about incorporating stuff. And it was funny because that same answer you gave, we did an event out here. And one of the people had said, it's like, as a therapist, you sometimes blend stuff and you don't literally every time you do something say, okay, hold on, we're moving to this. It just starts to incorporate. But sometimes I think there's people that don't, that are asking us, at least in the comments, about therapies that don't even include the ERP. So in all your years, have you ever met someone or seen someone get better not using ERP? Because that's what we get sometimes in the comments, people saying, ERP hasn't worked, I want to try something new. Is there a good treatment for people that ERP didn't work for?
I have three answers. But like one is partially an answer, but it's responding to a comment from Kay Lee, who said the only time DBT and ACT have contradicted ERP treatment for them is when the therapist didn't know much about OCD. I'll agree with that.
And Katya Moritz talks a lot about this, that like dive skills and things like that, like they're not meant to be used during an exposure, right? And so like if you're using the DBT emotion reg skills to try to get rid of your anxiety from your OCD, again, what we're teaching you is that anxiety is dangerous and we have to decrease it versus the ERP model of leading it.
And actually, I don't know if DBT tries to get rid of anxiety as much as cope with it. So in that sense, DBT would be helping me cope with the anxiety while I continue to do the exposure. And, as opposed to like, oh, make it go away. I think for the people who say ERP has not worked, frequently, I mean, there's, the one factor, this will not be a surprise coming from me. Frequently, nobody's really made the goal of treatment learning to deal with uncertainty. If I'm afraid that I might kill someone, and so we're doing all the exposure, having me think killing thoughts and everything. So I guess I can get used to having thoughts about killing, but like, how does that make sure I won't go crazy and kill someone? Like, why is exposure going to work? If my treatment is, I think it's a low probability event, but maybe I will go crazy and kill someone because low probability events happen, and we're all stuck taking a risk. But again, everybody drives a car even though they could get maimed, paralyzed, and disfigured. And right, the general plan is not dealing with it till I'm bleeding out, crushed under the metal. Not a great plan for when it happens, but if I avoid low probability events, I can't do anything. So we all are taking constant risks. So the idea that I'm learning, I'm actually learning to live with uncertainty, which kind of means if the worst happens, my goal is to try to cope with it. Not like it will never happen. I can't say, something will never happen. If I'm afraid of getting cancer, well, I sure as I can't say you'll never get cancer. If I'm afraid my spouse will die from some accident, well, I can't say that won't happen. If I can't get married and say, I know we'll never be divorced. I can feel it. I can hope it, but like, I don't get to know it, right? So everybody's living with, it's kind of funny if you think about how certain people want to be. If that certainty somebody has on the day they get married, where they are sure they'll be together forever unless they have ROCD. Right? But that great feeling of certainty is like wrong half the time. And this is what people with OCD are sacrificing their life for, to have that feeling that, may correlate with reality, but it doesn't reflect reality. So for a lot of people who say ERP didn't work, I find a good portion of them fall into that category. For somebody who said something else worked for them, I remember something Fred Penzel once said, that there's some things that will work for some people some of the time. But if you're picking a treatment, why don't you pick what works for most people most of the time? So yeah, I haven't seen a really good alternative to ERP. So although I'm sure there's some exceptions, it seems to be most people for whom it didn't work either weren't really trying to cope with uncertainty. And I have seen people run away from doing that. And it seems like, as far as I know, they keep suffering. But I'm sure there are exceptions. Low probability events happen, even good ones.
Well said.
Well, and one of the things, I always use as like a key indicator for me, for patients when we're talking about, is it, one of the things I get is like, well, how do I know if it's OCD or not? And often the answer for me is like, well, what happens if you don't well, that thing that's triggering, if you didn't witness it getting contaminated, what would happen? Oh, well, I wouldn't be as worried about it because I wouldn't know, right? It's dangerous because I know. And it's like, well, then that's OCD because, again, if it's actually dangerous, it's dangerous whether you know or not, right? It's not whether the person has a Band-Aid on their finger at the restaurant. That's not only triggering, or if, it feels triggering for OCD if you see it. But then if it's like, well, how do you know the guy preparing your food didn't have a Band-Aid? Oh, well, I don't know that, so I'm not worried about it. Okay, well, then it's not actually dangerous, right? Because if it's okay if it happens but you don't know, that's very, right, like that's OCD.
Yeah.
And that's the point of uncertainty, is that you're already living with it anyways, right? Like, we're not trying to teach you to do something new or something different. We're trying to teach you to just do what OCD doesn't want you to do, but what you're already actually doing, right? The things that OCD isn't triggered around, or the things that you don't know about, you're already living with that uncertainty. You just don't know you are, or you're not acknowledging that you are, but you are. And so what we're trying to get you to do is learn how to still live with it, even when you have to see it, feel it, or acknowledge it.
Yeah, I think you're exactly right. I mean, I do think when somebody says, how do I know if it's OCD or not? My immediate thought is, if you're asking the question, automatically it's OCD. And, part of your OCD is trying to figure it out, as if you said, as if that makes a difference. I know you've heard me say that when you recover from OCD, you won't be normal. You are better than normal. Because the average person without OCD doesn't actually cope with uncertainty that well. I mean, better than somebody in the throes of OCD, but they do a lot of denial, and I don't know if this was true for you guys, but I know my support group for people who cope, were doing really well with their OCD. When COVID hit, they did better than their families. They would come in and kind of laugh about, like, my family, they're like crazy. One of my former contamination people is going, I watch all the things, the rituals these people are doing. And, like, first of all, they're doing it wrong. I feel like I should hire myself out, and I can tell them how to ritualize much better than they're doing. Because the thing about uncertainty, it's not OCD, it's everything. And it's nice to have the feeling of certainty, but it doesn't mean anything. It doesn't mean you're safe. It's comfortable. So that's cool. When you have it, like, do I love my wife? I really feel like I love my wife. Am I fooling myself in some way? Well, I don't know. We get along. We've been together for 50 years. So if I'm fooling myself, I'm going with it till I know otherwise. I have the feeling I don't have to question it. I'll wait till I wake up, which, I don't know, 50 years, I seem to be consistent. So probably it's going to keep going. So that uncertainty is the rule. Everything is the odds.
Well, I always think, Liz makes a good point. We're not teaching a new skill. I used to work in restaurants, and every restaurant I worked in, the whole rumor that people like spit in your food doesn't really happen. We just talk crap about you behind, when we're in the back. But we all followed regulations the best we could, but we're also human. There probably were times that we served something that was expired, or something was 10 degrees lower cooked. So we always take that risk when we go out to eat at a restaurant, that the food.
And were you always conscious of making sure that you never put your hand in your mouth or touched your lips?
Oh no, that's the crazy thing, is like people just don't understand. Like, as servers, we were in the back doing like compulsions. We weren't wearing gloves and masks and everything. We were coughing around your food. So that's why when I tell my clients that don't want to accept that, certain things might happen, I'm like, you're already taking risks in these other areas. OCD just hasn't highlighted it. So therefore you don't really think about it. Most likely you'll eat your food and be fine, because that seems to be happening. But the thing that OCD has sort of highlighted, there has to be absolutely no chance it could happen, or even almost happen, or you feel like it might happen. And that's the big difference.
You remind me, I had a client who was telling me that she had intuitions, and she was always concerned that she should listen to everything because it might be a real intuition. And I asked her to ask her how many intuition urges she had a day, and she gave me a number, and we cut that number in half to be conservative, and calculated that in the last 2 years she had 160,000 intuitions that hadn't come true. Which she said, but sometimes they do come true. So I asked her to calculate her rate. How many times in the past years has she been correct? And by the way, all the time she had been correct had never been about something major, but she had been correct. And we then calculated that she had correct intuitions 1 in 16,000 times. And it's like, okay, I understand you feel this one is true, but 1 in 16,000. like, that's not a good bet. You're like, like if this was your mother's life, would you bet on this intuition? It's like, well, no. It's like, well, it's your life. So yeah, those feelings, they can feel true, but like how often? And of course somebody always remembers the exception, but again, all right, how many times right, how many times wrong?
Absolutely. We have a good scrupulosity question. It's from Yisrael at 12:17 your time, Amanda. He says, what advice can you give regarding it's a clinician. What advice can you give regarding a client with scrupulosity who wants religious guidance? How do you differentiate between getting knowledge and reassurance?
Well,
I mean, go ahead. I was just going to say, for me, I think one of the things that's really important is to think about what is the function. Is the function truly because they're trying to better understand their faith or understand, a scripture or talk to their family about it because they're exploring, or is it to gain certainty? Right. And John, I want to hear your thoughts, but like, again, is the function to gain something that's actually for OCD and our anxiety, or is it truly for our knowledge, our understanding, our religious beliefs, our practices? Is someone 18 and they're trying to understand who they are and how religion fits into their life? Or are they somebody who their religion hasn't changed, their religious beliefs haven't changed, but their OCD is targeting a new area or, wanting certainty around a certain thing?
Yeah. I think there are two issues. I think one, because many people who have scrupulosity, although they're very focused on like, are they doing the right or wrong thing, they actually don't think much about their relation to God. So I like to kind of explore that, like what kind of God are they going to choose to believe in everything. I think, if we can find a religious person to talk to, we can use them in treatment. I notice Zev is Yisrael Zev Schwartz, so I'm guessing you're Jewish. And so there are a few things. One is that, of course, if you were asking somebody for advice, you could only ask one rabbi, because you're not allowed to rabbi shop, because they know somebody might contradict each other. And so it's not like I go until I get multiple answers. I'm only supposed to go to one. And the rule is actually whatever that guy says is going to be true. And secondly, with that in mind, we could pick a rabbi who would generally follow the rule that we want you to make a guess as to what you think the rabbi would say. And if you have a guess, then you have to risk following that guess, even though it might be wrong. And the rabbi, especially if you've been asking him 10 million questions, it's likely to go along with that. And many religious figures are, because, it's like, I want you to make a guess and, follow that guess. And, so it has to truly be that if we were betting your mom's life, you have no idea what the answer is, but if you had to bet your mom's life, like, could you make a guess? So it would really have to be that you'd be willing to flip a coin for your mom's life rather than guess. So I can generally find a religious figure who will, go along with that, because they like the idea of, risking faith. I mean, faith is a risk always, because, right, the Lord doesn't speak to us. And again, if you're asking a religious figure lots and lots, then you are not making guesses that, and not trusting that God will be understanding.
Yeah, I like that too. It's one of those things where, people will rabbi shop, and it's like, you're not really looking for an answer. You're looking for an answer that makes the OCD happy, because you're literally going door to door until somebody will say something. I see that with when people have OCD around their health. Any doctor that tells them that they're probably going to be okay, they quickly run away from. But the doctor's like, yeah, you might end up damaged. See, I knew it. My compulsions do make sense. And then they go to compulsions. Well, this one doctor told me, and 1 out of 50 or whatever, or they find some article on page 18 of Google.
Right. Yes. I mean, after you've been through the mill, it's kind of like, they probably don't know what it is. You're going to have to take a risk.
Yeah. Another good question from Oh, sorry.
No, go ahead, Chris.
We have a question about relationship OCD from Ryder Girl on YouTube. She says, any tips or ideas for partner-focused ROCD exposures? Is it just only possible to do in vivo exposures?
I mean, the first question, the thing that makes that hard to answer is I would have to ask you a million questions to know what kind of things you are doing. And what kind of, I think there are some mental exposures, and I'm sure we could be way more specific if we knew more about you. But I think one of the prime things to do is, when we're with a partner, right, you're never getting 100% of what you want from your partner, right? That's like not happening. You're going to get like 70 or 80%. I mean, if it should be better than 30. If it's 30, you need someone else. But all right, so 80%. And the trouble is, in some sense, rather than always thinking, is this a perfect partner? Am I really in love? And how do I know I'm in love? I mean, I think I'm in love, but then I notice this problem, or I find other people attractive, and all these other possible things. So the very first part of accepting uncertainty is like, well, I know I'm not ready to leave now, because I assume, even though she may obsess about leaving, she doesn't actually want to leave now. And so the suggestion is that rather than looking every moment, and this is work, is like, okay, I'm gonna stay with my partner because they're good enough. Maybe they're second best. Maybe my true love is out there somewhere. I'm going to settle for this. So that is something they can think about. Why would I do that? So not like, are they good enough? And here's a list of all their good qualities and bad qualities. How do I feel about that? Like, why would I stay with this person as good enough? And that's kind of a beginning of a change, because, in some sense, we're always doing that. Because again, our partners may be really great in a zillion ways, but, it's not like they're perfect, and, obviously if I get married at 20, 50 years later, my partner's not going to look like a 20-year-old. So technically I'm settling for second best, as opposed to like, oh, wait, I got to get remarried because, they look as old as me. She looks way younger than me. So, I think I can do that as a preparation of like, why am I going to stay in this, even if it's second best. And another thing they can do that's really hard is when they're together, to notice what they enjoy. Now, when I say notice what they enjoy, I don't mean like, oh, wow, this is good, perfect, this is great passion, but just like, what do you enjoy, even if it's only 5%? Because, often when you're in the middle of obsessing, you don't notice anything, and so, or you're comparing it like, this is good, but oh, if I knew this would be better. It's like, okay, but you have OCD now. So let's have you just notice what little bit you enjoy, even if it's 5%, so that you begin to shift towards noticing the good things. I mean, I had one miracle cure this way. I do not expect this, where I gave that assignment to a guy and he came back and said, oh my God, this was such a great weekend. Like, I still don't know if I love her. And they were a cute couple, but like, if this is the way it was, I'm fine. That was really cool. I've never seen that happen again. Usually it's a much slower process.
When you were a keynote at OCD SoCal's conference, that was so life-changing for me as a clinician. When somebody asked about our OCD and you said that, it's like, maybe you just have to be okay with second best. And it was just something like you had gone on to say, like, look, if you keep chasing for the one, OCD is always going to tell you that the person you're in front of is the two. And that one is out there, this figurative, perfect person out there. And if you just search harder, and you'll be searching to your 102. So now when I work with a client with our OCD, it's like, we're going to find the two, third, fourth, fifth runner up at this point. But once a client kind of starts to get it, you think about it, it's like, third runner up at a Miss America pageant is great too. She might not have won the thing, but she's not terrible. And that's what the dichotomy of OCD. It's like, if I don't find the perfect person, I'm going to end up with the worst person in the world. It's like, the second best tennis player in the world is not terrible. It just means that there might not be one because they missed one lob that the other person didn't. So it's helpful.
Yeah, no, this is helpful. And I think relationship OCD can be difficult as well. It reminds me a little bit of a subtype that it's like, it's too, the more you try to focus on it or try not to, it's hard not to, or to, right, because you're with that person. And so it just makes it a little bit difficult. But again, it's about embracing the unknown, right? I asked somebody once and they said, oh, I would rate my marriage overall as like a 7. And I was like, oh, well, that's better than a 10. And they were like, what? And I was like, well, 10's not real. So like, to me, if you're rating something as a 7, that means like you had an amazing relationship, because no marriage is never going to have difficulties. Like, that's actually what makes the marriage better, right? Is it not being a 10, is the fact that like you go through hard times, you have to work through stuff, right? Like, that's an important piece. And really with OCD, again, we are not asking you to be miserable in a relationship, right? What we're asking you to do is be be in a relationship where OCD doesn't not just catastrophize, but doesn't completely destroy or take away any of the pleasure or joy that might actually be there, right? And for some people, even with your faith, a lot of people think, oh, scrupulosity treatment means you're going to make me less faithful, or you're going to change my faith relationship. And our answer is always like, not at all. In fact, we're going to remove OCD so that you can have a healthier, more functioning relationship with your faith the way you want and it's meant to be, not the way OCD wants.
Now you make me want to say two things. One, I'm in absolute agreement. When people see me for scrupulosity, they generally leave feeling they have a closer relationship to the God they choose. And the other one, because I think you all know that the only language I speak other than English is fluent cliche. and in speaking of picking the right person and all that, I would say that success is not making the right decision. It's coping with the consequences of whatever decision you made. Because that's all we can do, is we can move forward, whether what we did is working great or turned out in disaster. So it's always moving forward. I always feel when people worry about regrets, I think all regrets are kind of a waste of time, in the sense that I'm comparing my current life to a fantasy life. If I done this, everything would be right. It's like, life would be different if you didn't do it. Would it be better? You don't know. I kind of imagine if a woman came to me, out of an abusive relationship where every few weeks she would have the hell beaten out of her, and, are saying to me, John, a month or two in, I kind of saw this coming and I wish I left. And I say, no, you don't. Because 5 years ago, you were the kind of person who would pick somebody like that. How do you know you would not have picked somebody worse? So all I can do is move on and move forward. And, our goal for having people basically learn to love themselves. Right? And to like themselves. And so you don't get to be who you are without your past. So you may have suffered a lot, and OCD may have been terrible, and it's great to have it under control, but you don't get to be you without your OCD. And in fact, maybe you would have been some happier person, but you also might have been somebody you hated. Maybe you would have been some happier person, but without any empathy. I don't know what you would have been. So it's sad that you lost a lot to suffering. But on the other hand, if you're going to love yourself, then you went through that. Because, I think people, one has to realize that the easy part, OCD, is torture to have, but it doesn't make you defective. And so you have to really learn to embrace that. No, I'm not defective. I want to like who I am. And yeah, I'm stuck having gone through that, and let me have learned from it. We don't have to learn from adversity, but I think it's a good thing to try to learn from adversity, because, if you went through the crap, you might as well get the consolation prize.
Isn't that
what,
the truth?
I was going to say real quick, what you just said, John, that was how I healed. After my treatment, I was in a depression, and that was what was always shocking to me, and it was shocking to my family. They're like, look, you do almost zero compulsions. You have these ideas that you want to go do, and you're so amped about life, but you're so depressed. And it was because what you just said is like, my brain thought to when the OCD started, and there was like a fork in the road, and I had OCD, and if I wouldn't have, I would have been rich and a president and living this great, because your brain's going to make stuff up. And my mom was like, well, you were abusing alcohol and drugs. You're really like unhappy about life. You were struggling with your relationship with your dad. You were struggling with your sexual orientation. I don't think if you didn't have OCD, your life would have been amazing. I think there would have been different problems, that you would have had to overcome. And it really kind of hit home. And I did a little bit of that work with a therapist to kind of heal from having OCD to get into a better overall state. And that's the conclusion I finally came from. Exactly what you just said in your analogy is I wasn't in a good place when OCD hit anyways. I don't think my life would have been this perfect fantasy happily ever after like my head wanted to make it. It would have just been different, and there would have been different challenges and different struggles, and I had other growing to do. And just like you say, we become better after. If anything, after going through OCD treatment, I learned to love myself more, understand myself more, and feel more passionate about how much time goes by quickly, and to take advantage of every moment you have. And so that was really healing for me. And one thing I hope those with OCD on the call get is that your brain is going to tell you all the time that your life could have been a, should have been a, would have been a, It's going to be what it's going to be, but certainly going to be better if, you get the OCD in check.
Yeah, and I want to kind of remind everyone that it's really OCD treatment is such a beautiful life lesson, right? That we're not really teaching you something that you only get to use for your OCD. We're teaching you skills that you use for the rest of your life. My sister likes Disney and I don't, and she bought. I don't watch any shows, so I'm not, but she bought this like huge, huge Winnie the Pooh. And my daughter was terrified of it forever. And she would ask reassurance, like, we're not going by Pooh, are we? Like, Pooh's not out, is he? Like, and I finally, like, my husband and I would be like, no, Pooh's not out, Olivia, don't worry. And I was like, what are we doing? Like, we're going to go do exposures with Pooh. Like, this is crazy. I was like, we're promoting fear, right? And guess what? Like, now every day it's like, where's Pooh? I want to give him a kiss. Like, I love Pooh, right? And it's this concept of like what we're actually asking you to do. It's not rocket science. It's not disgusting or horrible or fear factor. It's teaching you how to face your fears, quit running from them or avoiding them, and lean into the uncertainty that is present in life, no matter whether you want to believe it or not, right? Like OCD makes us believe that, oh, if I don't feel anxious, then I'm not having to address or like, then I have certainty. Well, like, that's a false feeling. Certainty isn't real, even if you feel certain. And so really what we're teaching you is skills that everyone uses. Sometimes they just don't even know they use them. And so you, like you talked about earlier, Dr. Grayson, you become so much better. And when people are forced to use them or not use skills that they don't have because of situations like COVID, right? The rest of the world is kind of falling apart. And you're like, oh, like, this is easy. I know how to handle this, right? Like, I know how to address uncertainty and see where my anxiety is making decisions for me and coming in versus CDC and safety are making decisions for me and coming in. And so overall, I just want to reemphasize that uncertainty is at the core of OCD treatment, but it's also at the core of freedom in your life, whether you have OCD or not.
And if I could close with a story, because I was working with a woman who was really working hard in treatment and really doing well in it and really had conquered a lot of stuff. And she was doing amazingly well. And one day she said to me, I've had OCD since I was 4, and I've always kind of believed I could control things. And I still kind of feel that way. Like if I got cancer, and they said it was incurable, I'd find a way to get it cured. And I looked at her and said, okay, like, what would you do? She said, I go on the internet. I said, okay, so let me get this straight. You always go to the top docs and you're going to find something they don't know on the internet. And you're going to be able to tell the crap from the good stuff on the internet. And for some reason that hit her and she was like a little shocked. She was like, but what is there? And I just looked at her and said, the odds. All you have are the odds. She came back the next week and said she had been walking around in a daze, just repeating the odds, the odds. This was about 2 years ago. And she said that is when she stopped being depressed. So though she'd be doing well in treatment, she still kind of had that feeling of control. And so her whole life, in a sense, was a failure because she couldn't control anything. And on that day, she gave up. And since that day, she's no longer been depressed. So the odds are scary, but we can learn to cope with scary versus trying to achieve the impossible.
That's it, right? We can, and I always play, just, you have a video on peace of mind that I always play. It's like a 2.5-minute clip about uncertainty. And it's just about this. It's like, okay, so like false feelings of uncertainty, they exist, but like really, like they don't. OCD treatment doesn't change anything. We're not increasing your risk in life. We're not changing outcomes. It feels like we are, right? OCD plays this trick that it feels like we are. It feels like you're being more dangerous or more risky, but actually we're just getting you back to living. And the risks, the odds, they stay the same. Rituals don't change them, and we know that. They make us feel like they change them. Love it. Well, it's so good to see you and to always have you. We have so many questions that we continue to get. We'll add them to it, and and we know we'll have you back. So thank you for joining.
And it's always a joy. Thanks for having me.
Yeah, I just want to say real quick to anybody who didn't get their question, I literally was copying and pasting and putting at the top of our question list. Liz and I are going to get Grayson to come back, and that way we'll definitely get to your questions. We'll prioritize those for the ones that asked during this time. I want to quickly say, Kayli, I love, she's about to start a treatment program, and she said instead of thinking about how scary and difficult it is, she's going to think of it as an adventure or a challenge and not give up. That's such a good mindset. And thank you to everybody that came out and supported us today.
And just for one thing she should know about an adventure, because the truth about an adventure, it's something that sucks, but it's great to talk about afterwards.
Yeah.
So.
Exactly. A lot of good comments that people are saying about you, John. So everyone take care. Thank you for joining us for our Ask the Experts today. And we'll have John back. And as always, go to iosdf.org/live for all information on our upcoming live streams. Thank you so much. And don't forget to come to the conference, hang out with John, Liz, and myself in San Francisco, July 7th through 9th at the Marriott Marquis in San Francisco. Take care, and everybody have a wonderful day.
Bye-bye. Pleasure to be here.
Thanks, John.
Thank you.